Second white coat. Subscribe and like. Let's learn medicine together.
Welcome to This Explainer. Today, we're going to tear down a classic USMLE-style vignette and trace the exact clinical reasoning pathway, literally from the very first trigger words all the way down to the microscopic cellular damage. I am so excited to guide you through this because mastering this specific cascade, it doesn't just help you memorize random facts. It fundamentally changes how you understand urinary tract pathology. We're going to look at exactly how a simple, localized structural change causes a massive retrograde plumbing failure.
Here's our roadmap for this explainer. First, decoding the question stem. Then, anatomy of the obstruction. Next, the pathological chain reaction. And finally, high-yield board pearls. We are moving step by step, just like a successful test taker tracking the pathophysiology forward.
Section 1. Decoding the question stem. Isolating the triggers.
All right, let's dive into the patient presentation. In any board question, the clinical stem is just packed with clues, and our job is to isolate the high-yield trigger phrases before we even glance at the answer choices. So read this classic stem carefully. We have a 68-year-old man presenting with a weak urinary stream, hesitancy, and straining. Over time, he develops continuous urine leakage, nocturia, and frequent urination. When you see this cluster, you need to actively look for lower urinary tract symptoms, or LUTs, and immediately start sorting them into distinct physiological buckets in your mind.
First up, we isolate the obstructive symptoms, things like a weak stream, hesitancy, and straining. These are your mechanical red flags.
These obstructive symptoms tell us the patient is having severe difficulty getting urine out, and that points straight to a bladder outlet obstruction. Remember your demographics here. In a 68-year-old man, the most common cause of this specific type of outlet obstruction is benign prostatic hyperplasia, or BPH. So that's step 1. Recognize the disease from those initial triggers.
But, the clinical presentation doesn't stop there. The stem explicitly mentions frequency and nocturia. These are storage symptoms. So, why do they happen? Well, the bladder is now struggling against that obstruction. It fails to empty completely, leaving urine behind. And because it's starting partially full, it hits its maximum capacity way too quickly. That's what causes the patient to feel the constant urge to go, even waking up multiple times at night.
Finally, we have that critical phrase, continuous urine leakage. This is your absolute trigger for overflow incontinence. Notice this isn't stress or urge incontinence. The bladder has become so overly full that the pressure simply builds and builds until urine literally just leaks out passively. Think of it exactly like an overfilled cup, where water is just spilling over the brim because it has absolutely nowhere else to go.
Section 2. Anatomy of the obstruction. Pinpointing ground zero.
Now that we've decoded the symptoms and isolated our triggers, let's localize the anatomical defect. We need to know exactly where this obstruction is happening at ground zero. BPH occurs mainly in the periurethral or transitional zone of the prostate. This is incredibly important conceptually. Because it grows right around the urethra, as the prostate enlarges, it physically squeezes that tube. The physical pipe is quite literally getting compressed, shutting off the outflow tract.
Now, if you want to efficiently eliminate wrong answer choices on an exam, you absolutely have to remember this classic exam trap. BPH happens in the transition zone and does not increase the risk for prostate cancer. Prostate cancer usually arises in the peripheral zone of the prostate. Board examiners love testing this specific anatomical distinction to make sure you know exactly where the pathology originates. Don't fall for it.
Section 3. The pathological chain reaction. The retrograde plumber's nightmare.
Let's follow the pressure. We're going to track it backward, from the bladder up through the urinary tract to see this mechanical plumbing failure in real time. Because the bladder struggles to empty against the compressed urethra, it has to push much harder. It compensates initially through muscle hypertrophy. The bladder wall physically thickens to generate more force, which, by the way, is exactly why the patient in our clinical stem is experiencing all that straining.
Let's see how this builds over time. When urine cannot fully empty, all that force has to go somewhere, right? The back pressure logically forces urine backward in this exact sequential anatomical pathway, starting from the bladder, creeping up the ureters, into the renal pelvis, and finally into the delicate calyces of the kidney itself.
And here is the ultimate consequence of this backup. The ureters dilate, the renal pelvis dilates, and ultimately, this rising column of fluid begins compressing the vital, highly sensitive kidney tissue.
This dilation of the collecting system is called hydronephrosis. Hydro for water or urine, nephrosis for the kidney dilation. It acts exactly like an expanding water balloon deep inside the confined space of the kidney.
As that collecting system expands like a balloon, the normal renal parenchyma, which includes your vital tubules and crucial blood vessels, starts getting severely squeezed against the outer capsule of the kidney. It's essentially a localized compartment syndrome.
Think of stepping on a sponge. If you give it an acute squeeze, the sponge rebounds quickly once you step off. But chronic compression, like we see in untreated, long-standing BPH, is an entirely different story. If you leave a heavy weight on that sponge for years, it leaves the tissue thin, scarred, and permanently damaged.
And this brings us to the core pathology. This chronic squeeze causes a severe decrease in blood flow to the renal tissue. The compressed vessels lead to ischemia, which leads to cell injury, fibrosis, and ultimately parenchymal pressure atrophy. This is the exact medical consequence the examiners are looking for in our initial question stem. The kidney tissue literally wastes away from a lack of blood flow, all caused by mechanical pressure.
Section 4. High-yield bored pearls. Avoid traps and master the flow.
Let's synthesize this physiological cascade into the highest yield takeaways. I want to ensure you avoid the common traps and absolutely ace this concept on test day. Memorize this super high yield flow from start to finish. Track the journey from a simple urethral obstruction in the prostate, leading to urinary retention in the bladder, creating massive back pressure, causing hydronephrosis, which ultimately results in the compression of renal tissue, leading to ischemia and atrophy.
Now here is a crucial point and honestly a major pitfall for many students. Hydronephrosis itself is just the swelling. It's just the water balloon inflating. The actual irreversible damage is the chronic pressure choking off the renal blood supply. The ischemia is what kills the kidney, not the fluid itself.
So what is the simplest way to translate the board's question? When they throw a massive, confusing paragraph at you about a guy struggling to pee for 2 years, just strip away the noise. What they are really asking is, what happens when pressure chronically backs up into the kidneys?
The answer? Pressure atrophy. When you see this specific pattern of lower urinary tract symptoms evolving into systemic renal issues, immediately activate parenchymal pressure atrophy in your mind. From there, you can confidently eliminate the wrong choices, like glomerular sclerosis or tubular epithelial dysplasia, because those belong to entirely different disease pathways.
To wrap up our explainer, consider this for a moment. If a slightly enlarged prostate, a really simple, incredibly common mechanical squeeze, can silently destroy the intricate machinery of the kidneys over years, what other seemingly minor structural changes in the body are actually ticking biological time bombs? Keep that systemic perspective in mind as you study. Thanks for joining me on this deep dive, and I'll catch you in the next explainer.